Okay, the last category of things that we're going to talk about are things that affect the respiratory system. So this is going to include antihistamines, decongestants, antitussives, which stop cough, expectorants, bronchodilators, and some corticosteroids. So let's get into it. The first section is antihistamines. You all know what an antihistamine is. You've probably taken Benadryl before or used Benadryl cream, like if you have a mosquito bite. They also have some newer classes of antihistamines like Allegra, Claritin, and Zyrtec that we're also going to talk about. So these are the drug names. Diphenhydramine is Benadryl. Allegra is fexofenadine. Loratadine is Claritin. And Sertazine is Zyrtec. So those are the 4 different drugs. Now, I want you to note that these 3 drugs right here don't typically cause like drowsiness, but Benadryl does. Benadryl, it can often be used to help people go to sleep at night. It has like a sedation effect, although in some people, children or teenagers, it can actually have the opposite effect where it can kind of like keep them hyper and keep them awake. But Benadryl is a first generation antihistamine, which is kind of like a traditional histamine, while these 3 over here, I don't know if they consider them second generation, but they are non-sedating and peripherally acting. So that's what we're going to talk about. They work on the H1 antagonist, which means it's going to dilate capillaries and constrict smooth muscles. It's also going to increase GI and respiratory secretions and increase capillary permeability. So these drugs compete directly for a specific receptor site within with histamines. So let's say you are allergic to like tree pollen, like to oak pollen. Inside your body, you have several different cups. These cups are the receptors. So you have a cup here and you have a cup here. Let me see if I can have an actual cup to show you. Let's see. Ooh, sorry, that was my pencil cup. So here's my pencil cup. You have these little receptors in your body. And when you are outside and like working in the yard, tree pollen can come and get inside the cup. And that's going to cause a reaction in your body. You will have like runny, like itchy, watery eyes. You're going to start sneezing. Your nose will start running. You could start coughing or whatever. But that is like an allergic reaction because you're reacting to the pollen. So when you take an antihistamine, let's say this is the antihistamine. The antihistamine comes in and it blocks the pollen, the bad guy, I guess, from getting into the receptor. So it's going to stop that reaction from happening. So that's what these drugs are doing in the body. They are going in and they are filling that little cup so that the histamines from tree pollen or from dog dander or I can't think of anything else, maybe like ragweed or ligustrum hedges or cat fur or whatever, those can't get into the receptors and cause a reaction in your body. So that's what it means when it says competes directly for specific receptor sites with histamines. So these drugs can be used for a lot of things. A lot of them are allergy related. They only treat for symptoms. They're not going to stop you from being allergic to tree pollen forever. It's just going to stop you from getting the reaction, which is like the watery, itchy eyes, the runny nose, the sneezing, that kind of stuff. So it can be used for nasal allergies, seasonal allergic rhinitis, motion sickness, Parkinson's disease, sleep disorders, especially in the elderly, and the common cold, those cold symptoms that are really annoying. And it can also prevent the adverse effects that happen with blood transfusions, which Benadryl is the one you would use for that. So there are some adverse effects for the traditional drug, which is Benadryl, diphenhydramine. There is sedation because it is peripherally and centrally acting. Remember, these drugs over here, which I think you could consider second generation, those are peripherally acting, but Benadryl works centrally and peripherally. That sounds funny to say. They do have a drying side effect, which is anticholinergic. So there's going to be no sludge. Remember, sludge is salivation, lacrimation, urination, defecation, GI, I guess secretions or whatever, and emesis. So these drugs are drying. the non-sedating drugs, these like Allegra, Claritin, and Zyrtec, they're non-sedating and peripherally acting. Remember, they do not act centrally. There's fewer central nervous system adverse effects, and they do have a longer duration of 1 day. So typically, like I'm allergic to pollen, and I live in South Louisiana, and there is a lot of oak trees. So I take one allergy pill. I take one Zyrtec every single day at night, and it just stays in my system so that those cups, my receptor cups, are always filled to prevent the pollen from getting in. The pollen can't get into the cup because that receptor, that antihistamine is there. So there are some nursing implications. It's contraindicated in patients who have acute asthma attacks or lower respiratory diseases. And there is a caution that it can increase intraocular pressure in the eye. There's also caution with patients who have cardiac or renal disease, who have hypertension, asthma, COPD, peptic ulcer disease, benign prostatic hypertrophy in pregnancy. And there's a caution in the intraocular in patients who have increased intraocular pressure because it does dilate the pupils. So for this drug, you're going to need to assess urinary retention. Remember, it is causing drying, so it's going to cause urinary retention. So you do need to monitor that in your patient. And you also need to note that these drugs stimulate gastric secretions. Remember, we talked about that up here. And it can also accelerate the heart rate, so increase that heart rate. So those are the 4 drugs that are antihistamines. Remember, this drug has sedation, that's diphenhydramine or Benadryl, while these 3 drugs do not have sedation. These 3 drugs only act peripherally, while this drug acts both peripherally and centrally. The next category of drugs we're going to talk about are decongestants. I know I'm not going to be able to say these names right, but let's just try anyway. This is phenylphrine, pseudoephedrine, which are neosynephrine and Sudafed. Those are adrenergics. And then we have beclomethasone dipropionate, fluticasone, and ipratropium. That's becazone, Flonase, and Atrovent. These 2 are intranasal steroids. The fluticasone and beclomethasone dipropionate, those are intranasal steroids. And then this is an intranasal anticholinergic. That's the Atrovent. So again, these drugs are decongestants. They can be used for allergies, upper respiratory infections, just different nasal things, as well as hay fever and for sinusitis. The adrenergics work by constricting small blood vessels. The intranasal steroids work by turning off immune cells, but they have no systemic effect. And then the intranasal anticholinergics inhibit secretions. So they do have an adverse effect of rebound congestion. So like if somebody uses these drugs every single day, they're going to get used to it. And then once they stop, they're going to be super, super congested. That's especially prevalent with topical nasal adrenergics. The adrenergics do have systemic oral effects because it stimulates the heart as well as blood vessels, central nervous system, central nervous system, nervousness, insomnia, palpitations, and tremors, and as well as rebound congestion. And then the steroids, the intranasal steroids, there can be local mucosa drying and irritation. So there are available both orally and inhaled or topically applied. The oral drugs do have a delayed onset, while the topical or like the sprays can happen. They can happen quickly. Like you can see an effect or feel an effect within minutes with those drugs. So for oral, they have a delayed onset. They're less potent. They have no rebound congestion, and they're exclusively those adrenergics, the Sudafed and neosynephrine. And then the inhaled or topically applied, there's a rapid onset. They're very potent, and there is rebound congestion because the patients can typically overuse these drugs. For these patients who are taking these drugs, you want them to limit their caffeine intake, report any signs or symptoms. If those signs or symptoms last longer than a week, they need to talk to their doctor. And these drugs are contraindicated in patients who have hypertension, palpitations, or other CNS stimulation diseases. The next category we're going to talk about are antitussives. They're both opioids and non-opioids antitussives. Antitussive is like anti-cough, so just think like a cough syrup. There's codeine and hydrocodone, which are the opioids. And codeine's brand names are Robitussin AC and Dimetane DC. See how they both have C? The C is for codeine. The non-opioids include benzonatate and dexamethylorpam. I don't know how to say it. The benzonatate is Tessalon pearls, and the dexatromethophan is Robitussin DM. So these drugs are specifically for coughs. They're for non-productive or coughs that are harmful. And the harmful coughs can be like an elderly person who is kept awake from like their pneumonia, or somebody right after surgery who's just coughing a lot and it's hurting their incision or something, or possibly like breaking open their incision. These medicines can help with that. I mean, if there's a productive cough and the patient is actively coughing something up, you don't really want to stop that cough. You want to keep having the patient cough to get the stuff up. But these drugs are for non-productive coughs. So the opioid drugs work by suppressing the reflex to cough in the medulla, and the non-opioids work by numbing the stretch receptors in the respiratory tract, but they can be centrally acting as well. So typically the opioids are, centrally acting because they're suppressing the reflex in the medulla, while those non-opioids are kind of like going straight to the site of irritation and kind of numbing it, but they can also be centrally acting. So there are some adverse effects for the opioids. Let me see. For the opioids, there's sedation, nausea and vomiting, lightheadedness, and constipation. That's why whenever somebody's in the hospital and they're on a lot of opioid medicines, you see they most likely are taking like a laxative or something to help them go to the bathroom. That's because opioids can cause constipation and other GI issues. For the dexamethorphan, which is Robitussin DM, it can cause dizziness, drowsiness, and nausea. This is good for patients who have a dry cough and their chest hurts from coughing. And then the benzonatate, which is the Tessalon pearls, that can cause dizziness, headache, sedation, and nausea. And this is because that mucus from your respiratory tract can get into the GI tract. There are a few nursing implications. You don't want your patients to take any liquids 30 minutes after if they're taking their medicine via chewable tablet or a lozenge. You don't want your patients to use any heavy machinery, especially if they're taking those opioids, because of the sedation and the dizziness. Although the other drugs can cause dizziness as well, so no heavy machinery when you're taking a cough medicine. They do need to report any signs or symptoms to their doctor that's greater than a week. So if they've had a cough for longer than a week, or if they've had a persistent headache, a fever, or a rash, patients should change positions slowly, should not drink alcohol, and they should increase their fiber and fluid intake in hopes to decrease the likelihood of constipation from happening. So again, those are the antitussives. You have the opioids right here, the non-opioids right here. These are centrally acting, and they work in they suppress that cough reflex in the medulla, while these kind of go straight to the source of where the coughing is coming from and stop it right there. Next category we have are expectorants. These are drugs that if you have mucus or something in your chest or in your throat, this is going to get that out. It's going to I can't think of what I want to say here, but it's going to like help you cough it up and get it out. That's essentially it. Guaifenesin is Mucinex. It can also be sold under the name Robitussin, but we have it under as Mucinex here. And then acetylcysteine is Mucomyst. It is a mucolytic. So these drugs, again, are expectorants. They are for thinning mucus, so it's more easily removed. They decrease the viscosity of secretions, and they can also increase the production of respiratory tract fluids. So they can be used for the common cold, bronchitis, laryngitis, pharyngitis, paranasal sinusitis, pertussis, flu, and measles. And it can also be used for patients who have cystic fibrosis or acetaminophen poisoning. That's specifically the Mucomyst. Cystic fibrosis is like is a genetic disease that's like a generic overproduction of different mucuses throughout the body, whether it's in the respiratory tract or in the pancreas or in the GI tract or whatever. But this can help the patients thin that mucus in their lungs and help cough it up. There are some adverse effects, include nausea and vomiting, GI irritation, because this is stimulating the GI tract. And for the mucomist, it can also have the adverse effect of aspiration and a bronchospasm. So up here, we talked about acetaminophen poisoning. If somebody comes in and they've taken a whole bottle of Tylenol or whatever, you can give them mucomist or acetylcysteine, because that is an acetaminophen antidote. So fun little nugget right there. Nursing implications for these drugs is that they do smell like rotten eggs. So you kind of have to just tell your patient, like, look, this is not going to smell great, but it's going to help you feel better. And if you can, have them like eat applesauce afterwards, or just drink it really quick and just get over it and say, okay, look, it's going to taste bad, but it's going to smell bad, but just take this medicine. It's contraindicated in patients who have asthma. So it can help cystic fibrosis people, but that's because they have mucus that they need to get up, not for asthmatics. You should take caution in patients who are elderly or who have respiratory insufficiency, especially patients who have muscular dystrophy, because they may never have a forceful enough cough to clear their lungs. The inhaled nursing implications for drugs that are inhaled, you need to watch for respiratory condition. Or no, if it's inhaled, it's for a respiratory condition. If it's oral, it's for acetaminophen poisoning. I think that's what it is for mucomist. Increased fluids, they need to increase their fluid intake at least 8 ounces of water or more, and they should report a cough or a fever that's lasting longer than 1 week to their doctor. Okay, the next category are bronchodilators. This is epinephrine and metoprolol, and then several other drugs right here that I'm going to read off and try to say correctly. Albuterol, levalbuterol, SABA, S-A-B-A, salmeterol, LABA, L-A-B-A, and the brand names for those are Proventil, Zonopex, and Servarent. Epinephrine is a non-selective adrenergic, which helps the heart and the lungs. Metoprolol is a non-selective beta adrenergic, and it helps the heart and the lungs. And then these drugs right here are selective for beta 2. They're only going to help the lungs, only the lungs. So these drugs are bronchodilators. They are beta adrenergic agonists, and they stimulate the sympathetic nervous system, so they are sympathomimetics. They are for acute asthma attacks. Specifically, albuterol is for an acute asthma attack. It can also be for bronchitis, other pulmonary diseases, hypotension and shock. That's epinephrine. And it can also help with relaxing the uterus in premature labor. These drugs begin at specific receptors and it ends with the dilation of airways. Okay, let me re-say that. It begins at specific receptors that are stimulated and ends with the dilation of airways. This activates beta 2 receptors and activates CAMP, which relaxes smooth muscle in the airway, which results in bronchodilation and increased airflow. So there are lots of different adverse effects, and we're just going to go by each drug one at a time. The adverse effects of epinephrine include vascular headache, cardiac stimulation, anorexia, restlessness, insomnia, hyperglycemia, and tremor. The metoprolol, those adverse effects include an increase of heart rate, anginal pain, so chest pain, palpitations, tremor, vascular headache, and hypotension. Albuterol, which is specifically for acute asthma attacks, that can have the adverse effects of hypo or hypertension, tremors, vascular headaches, palpitations, and tachycardia. And all of these drugs can also just lead to nausea, increased anxiety, tremors, palpitations, and increased heart rate. These drugs, you need to take them as prescribed, and the patient should not omit or double up on doses, no matter what they do. The next category is an anticholinergic. ipratropium, which is Atrovent. This is not for acute asthma. It slows prolonged treatment and prevents bronchoconstriction. It says acetylcholine causes bronchoconstriction, and acetylcholine can also cause bronchoconstriction is airway narrowing. So acetylcholine equals airway narrowing. You can kind of think of that because it's a ACA. The C kind of looks like an equal sign, and the H kind of looks like an N, and you can think of airway narrowing. I don't know. That's a stretch. Anticholinergics bind to acetylcholine receptors, preventing the acetylcholine from binding, and this equals the airways dilating. So it's not for acute asthma. This drug can also cause like anticholinergic effects, which is anti-sludge. So it's going to result in decreased salivation, decreased lacrimation, urination, defecation, GI issues, and emesis. It can also lead to nasal congestion, heart palpitations, increased heart rate, anxiety, cough, and headache. This drug is nebulized, and you can give hard candy to your patient or just proper oral care to prevent dry mouth or to deal with dry mouth, I guess. Okay, the next drug we're going to talk about, there's two. It's a xanthine derivative, theophylline and amorphylline. Two different drugs. One drug is a plant alkaloid, and the other is a synthetic xanthine. Let's see. These drugs are for asthma, chronic bronchitis, emphysema, and COPD. These drugs increase the CAMP level by competitively inhibiting phosphodiesterase, which is PDE. So CAMP is not broken down. This results in the smooth muscle relaxation, which is bronchodilation, which increases airflow. It can also cause CNS stimulation, which results in increased force of contraction, increased heart rate, increased cardiac output, and increased blood flow to the kidneys, which is diuresis, which results in diuresis. These drugs are not frequently used because they do have a lot of different interactions with other drugs. The adverse effects include diuresis. Remember, we just talked about increased blood flow because of that CNS stimulation, nausea and vomiting, anorexia, gastroreflux during sleep, sinus tachycardia, ventricular dysrhythmias, and you should take caution in elderly patients because they have a decreased metabolism, and also take caution in patients who have cardiac disease. The nursing implications are that these drugs are available. The patient should not smoke because smoking increases xanthine metabolism. They should not have charcoal broiled foods, high protein, low carb, because they may decrease serum levels of xanthines through metabolic mechanisms. It's contraindicated in patients who have a peptic ulcer disease or GI disorders, and they should report any nausea, vomiting, restlessness, insomnia, tremors, or irritability to their doctors. So a way that I figured I wanted to remember this, especially with the no smoking or eating charcoal broiled food for your patients, it says there's xanthine derivatives, and I remember it by Xenon cannot come to the barbecue because she has a smoking hot bod. There was a silly movie that came out like 10 or 15 years ago. Okay, wait, I take that back. It came out in 2000. So it was 19 years ago, called Xenon Girl of the 21st Century. And she was like a young, pretty girl or whatever. And it's just a character that I remember. So I say Xenon can't come to the barbecue because she has a smoking hot bod. So they can't have like things that have been cooked over smoke, like a charcoal broil or barbecue. That's why I have it there. So I don't know. That's just something I've remembered. Hopefully it's just something random that it's like, oh, well, these drugs, the patient shouldn't have charcoal broiled food. It's just like a random thing. Like, okay, how'd you figure that one out? Okay, the next category are leukotriene receptor agonists, or LTRAs. They are non-bronchodilating, and the drug name is montelukast or Singulair. This is a new asthma medicine. It's prophylaxis or like a long-term asthma treatment. Prophylaxis means it decreases your triggers of asthma. It should be used in patients who are 12 years and older, and it can also be used for allergic rhinitis. It works because leukotrienes normally cause inflammation, bronchoconstriction, and mucus productions, But these drugs prevent that because they are leukotriene receptor antagonists. It makes your bronchioles stay open in your lungs. So inflammation is blocked and the person doesn't react to their allergen. This also stops smooth muscle contraction, which decreases mucus secretion. This also stops vascular permeability, which decreases neutrophil, leukocyte, and leukocyte infiltration into the lungs. So there are some adverse effects, especially in those younger patients. That's why you want to say 12 years and older. It includes depression, suicide ideation, and liver damage. So your patient does have to be over 12 to take montelukast. Nursing implications are that the patient needs to take this drug on a regular basis. You should assess liver function. It is an oral tablet, and the patient should see results from this drug in about 1 week. The next category are inhaled corticosteroids. I hope I can say this. Beclomethasone dipropionate. It's for chronic asthma or COPD. It works by stabilizing the membranes of the leukocytes, and these are the things that release harmful bronchoconstricting things into the lungs. It increases the responsiveness of bronchial smooth muscle to beta-adrenergic. So adverse effects can include pharyngeal irritation, cough, dry mouth, oral fungal infections. So patients should rinse their mouth after taking this medicine. And it can also lead to systemic effects. It's got low systemic effects because it is inhaled. So it does not have systemic effects. It's got low chance of systemic effects because it's an inhaled medicine. There are different options. It can be oral or inhaled. If it's inhaled, the patient needs to rinse their mouth out because it can lead to those fungal infections. And if it's oral, typically you don't want your patient to stop those drugs abruptly. They can take with food to help prevent GI issues or any ulcers from being irritated. And it can also be taken IV, which would be in the form of hydrocortisone methylprednisone, but we weren't talking about that one. We just kind of talked about that in class. If it's ordered with a beta agonist bronchodilator, they should use that 5 minutes before the corticosteroid because the bronchodilator is going to open up the lungs, and then that corticosteroid can get in there and get deep into the lungs. The next category are the phosphodiesterase 4 inhibitors. The drug here is roflumilast, Dalarsrep. Goodness gracious, these drug names are so hard. These drugs prevent coughing and excess mucus, so it can decrease COPD exacerbations. There are several adverse effects, including nausea, diarrhea, headache, insomnia, dizziness, weight loss, and psychiatric symptoms. And the last drug we have here is a monoclonal antibody, MAB. So it does end in MAB. Omlizumab Xolair, that's the brand name. So it's for asthma. It selectively binds to IgE, which is the immunoglobulin for allergies, and it limits the release of allergic response mediators. The adverse effect is anaphylaxis, so you need to monitor your patient closely. It's available by injection. Your patient should not smoke, and not be nearby any allergens that can affect them. They need to increase their fluid intake, take this on a regular basis, so have a regular administration of it, avoid excessive heat or caffeine, or in consuming caffeine, have prompt treatment for flu or other illnesses. As a nurse or healthcare provider, you need to get baseline vitals and respiratory history from your patient, and you need to monitor this drug for any therapeutic effects, including decrease in dyspnea, wheezing, anxiety, restlessness. The patient should see an increase in ease of breathing, respiratory patterns, and increased activity tolerance. So there we go. Those are the drugs that we have that specifically affect the respiratory system. Lots of different things to cover, but hope this helps.